Hi, happy Teach Me Tuesday. My name is Lisa Houston, and I am here with week 3 of 4 of our Heart Month. And for the NICU, that means we are talking about congenital heart diseases and defects. So if you've been following along, this is week 3. Today we are talking about transposition of the great arteries. We did have a bonus little mini one on Instagram this week where we talked about shunting and right to left shunting and left to right shunting and what that means for a PDA and what bidirectional it is. So if you haven't checked that out on my Instagram page, be sure to go back and check that out. But today we're going to talk about transposition of the great arteries, or TGA. And I can also tell you a little bit more about something I mentioned before coming up in a second. So let's review. So transposition of the great vessels, which is kind of what I feel like I knew this as a little young nurse. 20 years in now. I've been a NICU nurse for 20 years and an educator for 7. And I swear we just kind of like tweak these little names sometimes. But here we are now, transposition of the great arteries, or TGA. Great name still. But this is a congenital heart defect where the two main arteries that carry blood away from the heart, the aorta and the pulmonary artery, are switched. So when you think, whenever I think of like switched at birth or Parent Trap or the twins switch, like it's this whole situation where it's just completely flopped, where one thing is trying to do the job of another thing and it's putting blood in places it shouldn't be. So to really think about this, we have to go back and think about how a normal heart is pumping. So we think right side of the heart's job is to get blood that came from the body that is full of waste and deoxygenated to the lungs. And we do that via the pulmonary artery. I always think artery away. So it's going away from the heart via the pulmonary arteries over into your lungs where gas exchange can happen. The gas is exchanged, it goes in the pulmonary veins and goes back into the left side of the heart. The left side of the heart's main job is to take oxygenated blood and pump it out into the body via the aorta. So in a normal situation, right side is going to the lungs, left side is going to the body. But when those are switched and your pulmonary artery is coming off of the left side of the heart and the aorta is coming off of the right side, you can see how we would get in trouble with two things. One, we can't get the blood to the lungs to do the gas exchange. So we are going to have deoxygenated blood and we're going to have blood full of waste. And 2, we're then going to be pumping deoxygenated blood out into the body. So let's talk about this one more time. So this is a great picture again from CHOP, one of my favorite resources and websites personally that I use all the time. Now, here's that little thing I said I was going to bring up that I mentioned before. Something that was a game changer for me was the understanding that if you can picture what color the aorta is, that is telling you what color the baby is. So in this situation, with the flipping with TGA, this switching, the aorta is coming off of the right ventricle. So it is purple, it is deoxygenated. So you are going to have a cyanotic baby. See that? You see this aorta? It's attached to the right side. It's not supposed to be attached to the right side. The aorta should be attached to the left side. So the aorta, which is still going out to the baby, it's still doing its job by going out to the baby, it is going to be full of deoxygenated blood. Now you can see it is a slight shade of purple because it's relying on this atrial septal defect, the PFO, this big opening over here, in order to allow some oxygenated blood to still get in there. But then you see our poor little pulmonary artery over here coming off of the left ventricle. So the pulmonary artery's job is to get blood to the lungs. So it's still doing that. You still see the pulmonary artery going over there, but it's already oxygenated and it doesn't really have the waste. So we're still getting some of that deoxygenated blood via our PDA. So our PDA is essential in this diagnosis for treatment. So again, whatever color the aorta is going to be the color of the baby. Key step, more dark purple shirt for you today. Sometimes I'm planning these things. Okay, so let's talk about diagnosis. whenever I know, like, oh my God, there was an undiagnosed TGA, I'm like, how could that be possible? They're like completely flipped. But then I remember it's this little baby, and you're depending on the position, where the placenta is, and how they're looking at it, and someone having prenatal care regularly, and maybe getting more than one ultrasound. So I get it. Prenatally, it's usually detected during routine prenatal examinations. Sometimes it's not. So the baby will present with signs and symptoms. When that happens, then we have postnatal diagnosis. Gold standard is our old friend, the echo, right? This is the primary diagnostic modality for evaluating congenital heart defects. They may need a cardiac cath to go in and actually be like, hey, what are we seeing in here? And then a cardiac MRI with a 3D image that shows the heart's abnormalities. Again, the echo is going to be the gold standard, but we're going to get that because of the symptoms the baby is exhibiting. So that is going to be that blue or pink tint, blue or purple tint to the lips, the skin, the nails, some cyanosis, rapid breathing. You're going to be having this like extra fluid on the lungs that the lungs don't know what to do with, because they're like, whoa, dude, you're already full of oxygen. Why are you in here? Right? So the lungs are having extra pressure on them, so they're going to be working harder. The baby might have difficulty feeding, poor appetite, poor weight gain. And then one of our other critical signs is if we do a pre and post ductal, because when would we be doing that? If not because they're in the NICU, but for another reason, which would be our CCHT screening, where we are required by our governing bodies, such as your state, to check for congenital heart disease before our baby leaves. And this is a situation where the pre-ductal saturation will be lower than the post-ductal. And again, that's because the aorta is coming off the right side of the heart. That first branch of the aorta is sending that deoxygenated blood, because that's what it's full of, because it's coming off of the right side instead of the left side, which is not great. And so over here, before the ductus arteriosus, you're going to have that deoxygenated blood. Now, postductally, you might have a little bit of oxygenation because of the PDA, but if you have a difference in those where the pre is lower, that is very unusual. So again, those newborns with TGA are typically going to present after birth with cyanosis. They're going to have that rapid breathing. They need prompt intervention to prevent severe hypoxemia, acidosis, and cardiovascular collapse. So what's our job? As I mentioned, I do not work at a place where we crack open the chest and do open heart surgery. So I love knowing what is my immediate job. What do I need to be doing? What can I be doing? And this is a situation where PGE is your best friend. Alprostadil, PGE1. We're going to get that going to keep the PDA in the foramen ovale, or that AST, open so that oxygenated blood can still get to the baby, and unoxygenated blood, also blood that's full of waste, can get to the lungs. Remember, the number one way that we as human beings get rid of our CO2 is by exhalation. So we have to be able to get the CO2 into the lungs in order to exhale it out. Let's do it together. Right? Exhale out our CO2. So on admission, what's our job? We want to get that PGE started right away. Get a line in, get our access, get our PGE started. We want to get oxygen supplementation to alleviate hypoxemia and cyanosis as needed. We're going to have close monitoring of our vital signs, our oxygen saturation, our hemodynamic status, and our blood pressures. 4 extremity blood pressures, key. Pre and post ductal saturations, key. These are going to be things that we can do immediately, right there at the bedside with us. Obviously, we're going to want to get an echo. That's going to happen within, that first few hours of life, depending on kind of when it is. Echoes are not always done in the middle of the night, but they can be. I've seen it happen. So if we're waiting, it would be done in the morning, but again, having our PGE going. So surgical treatment is absolutely necessary for babies born with TGAs. Without a doubt, they have to have a surgery. Some of them require an immediate surgery where they have a balloon atrial septostomy, or a BAS, and that takes place almost immediately after birth. These are babies where their little ASD or their PFO was too small. It wasn't big enough to really allow the mixing, and so we have to get in there and make it bigger before we can even do anything else. Otherwise, these babies are going to have horrible oxygenation. And so if you think of the cascade of poor oxygenation, that is poor perfusion, at risk for neck, liver failure, kidney failure, all of those things. So that's going to help us get in and stabilize the condition of the baby. This is kind of like a patch. It's a thing that's going to help, but it's not going to cure the problem. It is not going to give our baby a lifelong repair that they can do. In order to do that, you have to do the atrial switch. Now, again, I'm going to remind you, which I just did a second ago, that I do not work in a hospital where I have ever seen this happen. So this is something that I have to dig into so that I understand what's happening. I really love CHOP again. And if you look at these pictures, so if you're looking on here, pause and zoom in. But I look at these pictures and I'm like, so we just like disconnect and like reconnect. Like cardiovascular surgeons are pretty amazing. But essentially that's what we're doing. So we're switching, it's an atrial switch. We are going to switch the locations of the things that are currently in the wrong location. So the aorta is disconnected from the right ventricle and attached to the left ventricle. The pulmonary artery is disconnected from the left ventricle and reattached to the right ventricle. We get our coronary arteries back in where they should go. And then we have normal blood flow to the systemic and pulmonary circulations. So what I want you to notice, back to my point about my old friend the aorta, is in our first picture, the aorta is purple, right? This is during the disconnect at the beginning before anything's really going on. Then we get in here, we've now moved the aorta over to our left ventricle. Look at what our old friend the aorta is. She's red again. That means she's full of oxygenated blood. So looking at the color of the aorta, we've got our coronary arteries back in our little good places here. And now we can resume that proper blood flow so that the oxygen-rich blood can be pumped to the body. Now, I say this kind of lightheartedly, like, oh, they just disconnect these things and reconnect it. It's a big deal. And these babies do need a lot of support while they're going through this. Atrial switch, I mean, looking at these pictures, I'm like, oh yeah, that's no big deal. Obviously, it's a very big deal. And a surgeon is in there, a very well-trained cardiothoracic surgeon. But the babies are going to be on life support for quite a period of time while they're getting all this switched out. So let's think about what we're going to talk to our parents about. So these babies are going to have lifelong care by a cardiologist. We're going to have to watch for their heart function, EKGs, echoes, cardiac MRIs, following those other things that can put stress on the heart, including blood sugar, cholesterol, valve function, if there's any blockages in there. Maybe they're going to have more cardiac caths in order to follow through because they're at risk for having heart failure down the road. But the prognosis for babies born with TGA has improved significantly, again, with these surgeries that we now can do. And the majority of affected children will thrive in their life, and as long as they've had their appropriate management with medical and surgical, being on top of their meds, watching their nutrition. Again, these babies might need to be on high calorie, low frequency feeds if they're still tired during their transition. They might need to be on higher calorie feeds while they are recovering from their major surgeries. So watching their nutrition, watching their medication, are they on blood pressure medication? Are they on cholesterol medication? And just keeping all of that intact and following up with your cardiologist is going to be key. So to recap, TGA is just this great thing where we have these two main guys that are usually kind of look like this, switched, and we've got them coming off of the wrong areas. So our aorta, which needs to pump oxygenated blood to the body, is instead pumping deoxygenated blood. Hopefully mixed, because we have an ASD that's allowing some mixed blood, but it's coming off of the right ventricle. And then our pulmonary arteries are coming off of our left ventricle, and so we can't circulate the blood to the lungs in order to exchange our gases. So we're relying on our PDA in order to allow some of that blood to come in and get rid of some of that waste. But with a good diagnosis, appropriate intervention, getting your PGE started right away, getting the baby to a care center where they can receive their open heart surgery is going to greatly affect them and allow for good survival and allow them to lead normal lives. So that is our recap of TGA, or transposition of the great arteries. I hope you enjoyed it. Next week will be week 4, and we have saved the best for last, my personal favorite heart disease to talk about, heart defect. You're all going to probably think I'm crazy, but we'll talk about it next week. Until then, you can find me here and comment anything, or go over on Instagram where same thing, Houston, we have and we can dissect that. So have a great Tuesday, and I will see you next week for our 4th installment of our cardiac defects.